Hello, ladies and gentlemen, sisters and brothers, all genders and identities. My name is Yvonne Weldon. I am a Wiradjuri woman from Cowra here in New South Wales, from the waters of the Clare, which later became known as the Lachlan, and of the Murrumbidgee rivers. Unfortunately, there aren't any people that have met legal requirements to be a traditional owner of the lands that I am on. And so I am a representative of the Metropolitan Local Aboriginal Land Council, who are caretakers with cultural authority under the Aboriginal Land Rights Act. I would like to pay my respects to elders past and present, to all First Nations, to you and the ancestors of the lands that you are on. Some people have views about welcomes to country and whether we need it to be done. There is so much across this continent that isn't known. Sometimes it isn't respected, and this further dispossesses the First Nations. I thank your organisers for including me, the First Nations, and all of us. We can achieve so much more when we work together. A welcome to country is more than just words. It is a spiritual process. By honouring the ancestors' footsteps we are walking in, continuing the practice of the many generations before us to the many generations to come, where the sharing and the trading of our resources, our knowledge and our traditions has been my people's way of life since time began. We traded and shared amongst the nations, the tribes and the clans that have existed here for over 65,000 years, traded for necessity and not for empires. The boundaries of our traditional owners are not defined by the hand or by the pen, but through the natural landscapes of the earth. The Eora Nation's country covers the Hawkes River in the north, the Nepean in the west, and the Georges River in the south. On behalf of the Metropolitan Local Aboriginal Land Council, the elders, and the members, I welcome everyone to the lands of the Gadigal. I acknowledge Gadigal people and also the people's lands that you're on today, whose spirits and ancestors will always remain with this land, our Mother Earth. As we all gathered here, let us all acknowledge the many warriors that created pathways for all of us, the ones recognised and those we've never heard of. Our songlines and our customs have sustained us, and they're embedded into the core of this nation, and also within each and every one of us. My people are the oldest living culture of the world. The challenges that we're dealing with, the cycle doesn't only change because of policy or legislation. It cannot always be about data and the bottom line. Our lived experience must be included as well. Human life and people's opportunity, or lack thereof, cannot be rationalised to balance what will never be equal. Utilise your learnings to help others, sharing along the way. Use your passion and your commitment to make positive change that is so needed. As you connect, learn and share, today, tomorrow and beyond, bring my people, your people and all our people together. We need to help each other age well and have a greater safety in accessing our medications so we can live our lives better. All of us can make a positive change to each other, our world around us, now and into the future. That will become the milestones of our future, all our futures, an inclusive one. So we can have one. It's important to aim for prevention, provide care and compassion. You can make a difference long before any damage takes place. Be the healing before any trauma. So let us all draw upon my people's spirits as we continue on our journey. May my people's spirits walk with you and guide you as we strive forward for us all. Again, on behalf of the Metropolitan Local Aboriginal Land Council, Ninyini, Nala, Wongan, Mari, Bajari, Gadi, Nurda, welcome to Gadigal country. This always was, always will be Aboriginal land. Thank you and have a wonderful day.
Welcome to the National Medicines Symposium 2024. I'm your host, Tegan Taylor, a health and science journalist, and it's my privilege to be here today as we delve into the critical issues facing our healthcare industry. Safe and appropriate use of medicines in an ageing population is a complex balance between managing disease and avoiding medication-related problems. As the population ages, more Australians are living with multiple chronic diseases and may take multiple medicines, which is known as polypharmacy. This puts them at increased risk of medicine-related problems. Today, you're going to hear from experts, healthcare professionals, and policymakers as we discuss key and emerging issues around medicine safety in an ageing population. We'll explore innovative strategies for enhancing medication safety, reducing polypharmacy, and improving the quality of life for all Australians. Hopefully, this inspires you to consider how these apply to your practice and the healthcare setting where you work. Thank you for being here today. In this first session for today, we'll get an idea of the landscape of the quality use of medicines in Australia with some key policy leaders in this space. Firstly, we're joined by the Minister for Health and Aged Care, the Honourable Mark Butler.
Well, good morning, everyone. I'm so sorry I can't be with you in person today. To begin, I'd like to acknowledge the traditional owners of the land where I'm recording this, the land of the Ngunnawal and the Ngambri peoples. I extend that respect to the elders past and present and to First Nations people who are participating today. Welcome to the 2024 National Medicines Symposium, hosted by the Australian Commission on Safety and Quality in Healthcare. An important event that brings together leaders from across the health sector to discuss key issues around medication safety in an ageing population. Important to all attendees and important to all Australians who will benefit from safer, more sustainable use of medicines. Many of you here today already know the complexities and challenges of medication safety. You're confronted with them daily. Use of medicines is the most common intervention in healthcare. Used appropriately, medicines help us to keep well, to recover from sickness, and to improve our quality of life. But inappropriate use can increase risks of adverse outcomes with specific consequences, particularly for older Australians, such as delirium, falls, frailty, cognitive impairment, and even hospitalisation. As the population ages, more Australians are living with chronic diseases that require multiple medications and multidisciplinary team coordination of their care. Our government is delivering better outcomes for Australians through a range of health measures. We're delivering cheaper medicines through 60-day prescriptions, a landmark initiative that has been welcomed right across the country. Patients living with stable, ongoing health conditions can halve the number of visits to their doctor and to their pharmacy to renew and then to fill their scripts. Around 300 medicines are now available under this initiative. There are also several pharmacy programs that support the quality use of medicines for older Australians at home, as well as in residential aged care. This allows greater trust and confidence in the care older Australians at home and aged care receive. Pharmacists are visiting people in their homes and in aged care to regularly review medications, giving older people and their families shared decision-making. All of these measures add value, and combined they offer opportunities for safer and more sustainable medicine use. They are a vitally important aspect of improving the safety and the quality of healthcare in Australia. I look forward to hearing about the approaches to deprescribing of medicines and the challenges of polypharmacy during today's symposium. These are global concerns and central to Australia's response to the World Health Organisation Patient Safety Challenge of Medication Without Harm. I wish you well in your deliberations and I look forward to hearing the outcomes. Thank you all very much.
Thank you, Minister. It is my pleasure now to introduce Professor Anne Duggan. Anne is the Chief Executive Officer at the Australian Commission on Safety and Quality in Healthcare and a highly respected gastroenterologist with significant leadership experience in a range of healthcare settings. Anne is also a Conjoint Professor at the School of Medicine and Public Health at the University of Newcastle. Anne is passionate about improving healthcare services through sharing knowledge and collaborating across the health system. Welcome, Anne.
Good morning. I'm Anne Duggan, Chief Executive Officer of the Australian Commission on Safety and Quality in Healthcare. And it is my great pleasure to welcome you to the National Medicines Symposium 2024. The Commission plays a pivotal role in leading and coordinating improvements in safety and quality in healthcare and supporting a safe and sustainable health system. Our work is in partnership with patients, carers, clinicians, and healthcare providers. Key components of this are programs that promote medication safety standards for both primary and acute care settings. This year's National Medicines Symposium focuses on the safe and appropriate use of medicines across these settings, with a focus on those most at risk of medication errors and poor medication management, the ageing population. Today, we will be exploring strategies to address the burden of polypharmacy and to reduce medication-related harm, such as using comprehensive medication reviews and deprescribing of harmful and unnecessary medicines. We will also hear a status report on Australia's response to the World Health Organisation's Global Patient Safety Challenge on medication without harm, and guidance on where we need to focus our future efforts. The symposium will provide insights about the valuable contribution of digital innovation and tools to support safe and effective medication management, such as real-time prescription monitoring. We will also hear about the Commission's work on a stewardship framework for medication management at transitions of care. Careful consideration of how we use medicines ensures appropriate care for individuals, a more sustainable health system, and a better environment for us all. Safe and appropriate care in the community should mean fewer admissions for disease progression or medication-related complications. Through collaboration and knowledge sharing, we can leverage our collective expertise in medication management to improve health outcomes and quality of life for all, now and into the future. Thank you all for joining us today. I look forward to the presentations and discussions ahead.
Thanks, Anne, and thank you to everyone who's joining us today from around Australia, and especially those who have submitted questions. They've been really helpful in planning today's event. And you can still submit questions throughout the day via the chat function on your screens. Let's now learn more about the history of quality use of medicines in Australia and the National Medicines Policy Framework with Professor Libby Roughead.
Thank you, Tegan. Hello, everyone. I've been asked to set the scene for quality use of medicines in Australia today. And so what I want to do is start by talking about some history. How did quality use of medicines come into being? Then I want to go on and look at how we went about building, what did we build, and then where are we today, and what are the challenges that face us as we go forward? So the first thing that's really important to remember is that quality use of medicines was a consumer-driven movement. It started in the 1980s when the consumer movement led consumer studies for consumers about problems with medicines. And the first one done by the Council of the Ageing, Too Much of a Good Thing, looking at harms from non-steroidal anti-inflammatory drugs. Then the Consumers' Health Forum led the way with two seminal documents towards a rational medicinal drug policy and towards a national medicines policy. These documents outlined all of the things that the consumers thought were necessary to achieve quality use of medicines. It's fair to say that many of the health professionals at the time were a bit embarrassed that they hadn't driven this kind of activity. And then the Health Minister responded by establishing a National Expert Advisory Committee to develop a national strategy for quality use of medicines and a representative committee to advise on the national medicines policy. So in 1991, we had the then policy, the now strategy on quality use of medicines came into being. And this document laid the groundwork for what I would consider is a fundamental cultural shift in the way we thought about medicines. It did that by providing a new definition of quality use of medicines, and I'll come back to that. It was underpinned by behavioural theory. It identified principles of working that included the primacy of consumers, partnership, consultative, collaborative, multidisciplinary activity, and systems-based approaches. And of course, it had indicators to evaluate progress. The definition was really important. It was changed the way we thought about medicines, and it was the first time globally that we thought about medicine use beyond the medicine. That if we wanted to understand quality use of medicines, we had to think through all the management options. When we needed a medicine, then it was appropriate selection of a medicine, and then
once we were using a medicine, the safe and effective use of that medicine. So the whole medicine journey. But the other important thing was the behavioural focus. The expert committee of the time reviewed all of the behavioural theories that were available to it. It looked at behavioural theories around how do individuals learn, and social cognitive theory was one of them. It looked at how do individuals learn over time, and this one, the trans-theoretical model, is the one on the slides. It looked at how do communities change, informed by health promotion models such as precede, proceed, and how do communities change over time, informed by models such as the diffusion of innovation. It looked at persuasion and communication theories to think about how do we give appropriate messaging. It synthesised all of those theories into one model, thinking about how do we raise awareness of problems, provide knowledge that allows people to find solutions, allows actions, allows skill development, and then appropriate motivation to perform behaviours. How do we move people through these stages of change? How do we provide opportunities for rehearsal, repetition, trial, action, the development of self-efficacy? And what are the strategies we need to do that, such as promotional activity, guidelines, knowledge building activity, skill building activity? And so it outlined the kinds of activities we might need. All of this was put together to this vision that we used to call the quality use of medicines pyramid. That if we had all partners adopting those principles of quality use of medicines, the primacy of consumers, partnership, consultative, collaborative, multidisciplinary activity, if we had them then using all of the building blocks for quality use of medicines, policy development, facilitation and coordination, objective information, education and training, services and interventions, and research and evaluation, if we moved through all of the stages of behaviour change, from awareness raising to knowledge to skill development, and then through all of the health levels of the health system, primary care, secondary care, tertiary care, if we could pull all of that off, we would have quality use of medicines and healthy consumers. It's fair to say that this was visionary. It was built by a group of experts in 1991. It would now be considered co-design and theory-informed. But this vision was realised 15 years before the first academic papers on the topic. This vision emboldened us who were around at the time to build, because when this vision was created, there were very few resources to support quality use of medicines in Australia. We had antibiotic guidelines. Respiratory guidelines were about to be published. We had Australian Prescriber. We had the Adverse Drug Reactions Bulletin, and we had approved product information. That was it. And so the 1990s were the era of building. We spent a lot of time gaining understandings, and a lot of the documents on this screen developed by the consumer movement. We set about building new models of practice, so developing academic detail, developing medication review programs, developing the models for those services to be implemented nationally. We set about creating resources that didn't exist: consumer medicines information, the Australian Medicines Handbook, indicators for monitoring progress at local and organisational levels. And of course, we set about building standards of practice and processes of care to guide the way we practiced. And so by 2003, I was doing the evaluation, and if I went to colour in that pyramid, we had built nearly everything we set out to achieve. You mightn't be able to see the detail on this slide, but everything on the left-hand side in black is successfully built. And there's only a few things in red that were articulated in that 1991 policy that we hadn't built. So we were well on the way to having awareness across the country and now enabling activity. So the 2000s, I would argue, was the period of enabling and sustaining. We had a focus on building a skilled workforce and increasing participation. NPS MedicineWise was established and expanded. We had medicine review services funded and then expanded. And so by 2018-19, we had lots of participation, lots of people participating in academic detailing, lots of people doing case studies and clinical audits. The medical schools had all adopted the curricula. We had 150,000 people a year receiving medicine review services. And of course, there were lots of hits to the NPS MedicineWise website. Every professional organisation had endorsed quality use of medicines and had it in their standards or training. So where are we now? In 2022, a decision was made to restructure the way some of the quality use of medicines activities were funded. It comes at a time when new challenges are emerging, and it's 20 years since the National Strategy on Quality Use of Medicines was last revised. So this change offers us a chance for reflection and renewal to think about the challenges going forward. So what are the challenges and what might we need to do? This is my list. 21st century, I think of it as the challenge for medicine safety. Our populations are ageing and we're living longer with multiple illnesses. We have multiple health practitioners involved in people's care. We have new medicines entering the market and they're most commonly used with existing treatments already there. We have new understandings of genetic and metabolic systems that are changing the way we understand the effects of medicines. We also have new understandings of neuroscience that are changing our understanding of the role of non-pharmacological treatments. Our clinical trial system and our health system hasn't yet caught up with these changes. And then on top of that, we have digital technologies, social media, and artificial intelligence, which are changing the way we interact, gather knowledge, and communicate. So let's look at some of those challenges. And challenge number one is that of multimorbidity and polypharmacy. We've got older, and along with that, we live longer with more illnesses. So the prevalence of multimorbidity has risen fourfold in Australia since 1985 and 2005. It's very quick. And then we treat illnesses more intensely. It wasn't until 1998, that's a long time after the original policy was written, that the first recommendations globally were for add-on therapy, and that was for diabetes. If you didn't get better with one medicine, you added a second. Before that, we always switched. And then in 2000, we saw similar add-on therapy for hypertension. And so what this meant is that we've changed the way we use medicines very quickly, and we're now in the era of polypharmacy. These are data from the UK, and you can see in 1995, 20% of people who were 65 and over were on 5 or more medicines. Fast forward to 2010, and it's doubled. I can show you exactly the same data from the USA. And then on the next slide, we've got Australia, slightly different data, but this is from the National Health Survey, and it's in 2022, and the number of unique medicines people were dispensed in the last 6 months. And what you see is that 70% of people 75 years and over have had at least 5 different medicines dispensed in the last 6 months. And the problem with that is it all interacts. If you're unlucky enough to be on 10 medicines concurrently, chances are you'll have 14 different interactions going on. And we don't think about this. Back in 1991, we dreamed guidelines into being as a way to solve this problem. But of course, the guidelines weren't developed with the idea of multimorbidity in place. And so again, I've got a UK study on the screen. It's a little old, but 133 serious medicine interactions. If you followed the diabetes guidelines, and the 11 other guidelines for common conditions that are commonly comorbid in people. Now, no one will have all 12, but you can start to see the problem. So we need to think about how this goes forward. Challenge number 2, the medicines we use, they're more costly, they're more complex, and they're frequent specialist prescribed. So using medicines has got harder. In 1991, when we first started, medicine use looked a bit like this. Cardiovascular, anti-infectives, respiratory medicines, medicines affecting the nervous system and the gastrointestinal system, they accounted for the majority of use. So it's not surprising that we got GPs involved in quality use of medicines. Fast forward to now, and those medicine classes still account for the majority of use. But look what's happened to the anti-neoplastic and immunomodulatory medicine use. It's risen 13-fold since the original policy. And that now accounts for 40% of PBS costs. And so there's a real need to think about how do we engage specialists in the quality use of medicines movement. Challenge number 3 is care at home. We're caring for many more vulnerable people at home. So it's a major shift since the policy was first developed. We've got aged care at home, we've got hospital in the home, we've got mental health care and disability support all happening in the home. Unfortunately, we don't have a lot of insight into how well we look after these people from a quality use of medicines perspective, but we do know that there are lots of barriers to their care, barriers accessing services, barriers accessing information. And lastly, challenge number 4, grabbing the opportunities in changing service delivery. It's an exciting time where we're seeing lots of new developments in the way we deliver healthcare. We've got expanded prescribing with pharmacists and nurse practitioners. We've got new models of care with pharmacists in aged care, in general practice. We've got virtual models of care. We've got state-funded quality use of medicines programs, which mean we've got activities outside of the hospital setting and now in primary care, sometimes funded by the state governments. And we've got new opportunities in digital health, such as automation, digital biomarkers, and precision decision support. And of course, we've got new understandings from system scientists so we can rethink the therapeutic continuum from the biological to the social. So going forward, thinking about renewal, what do we need to think about? Consumer-led and consumer-driven activity started the quality use of medicines movement. We need to think about how we re-engage and make this consumer-driven movement happen again, because many of the activities we had, such as medicines information services, persons and medicine talk, no longer happening. Dialogue, collaboration, facilitation and coordination. There are many more groups involved in quality use of medicines activities. And so we need to think about how we create opportunities to coordinate this activity and address emerging issues that are outside the remit of any one of those organisations. And of course, we need to engage medical specialists in quality use of medicines. We need many more effective structures for dealing with multimorbidity and polypharmacy. Deprescribing has emerged as one focus to deal with this, and there are many good resources developed, but they're not yet in routine practice and they're not yet integrated with some of our other resources, such as product information. And then, of course, we've got the digital health initiatives. This has brought a whole new stakeholder group to the table, and we really need to think about how we engage and communicate with this stakeholder group and get them understanding the cultural underpinning of quality use of medicines. And then think about how social media artificial intelligence can be used in a positive manner to stop the misinformation that can contribute to overdiagnosis, unnecessary care, or avoidance of needed care. So I'm going to conclude there by saying the original policy provided us with a vision to be bold, enabled all sorts of activity to be dreamt and built into being. I think the vision still holds true today. Consumer-centred, theory-informed, comes out of lived experience, multidisciplinary, collaborative, systems basis. And so I'm urging you to consider how we might re-envision the vision and build quality use of medicines to address the challenges of the 21st century. Thank you.
Thank you, Libby. Monitoring polypharmacy and responding to inappropriate polypharmacy is one of the actions for Australia's response to the World Health Organisation's Patient Safety Challenge, Medication Without Harm. To tell us more about the Commission's latest status report, we have Steve Waller.
Good morning. My name's Steve Waller, Senior Advisor for Medication Without Harm at the Australian Commission on Safety and Quality in Healthcare. It's my pleasure this morning to talk to you about the WHO Global Patient Safety Challenge, Medication Without Harm, and report on Australia's response. By way of background, in 2017, the World Health Organization launched the third Patient Global Safety Challenge, Medication Without Harm. In 2019, the 10th National Health Priority was named as Quality Use of Medicines and Medicine Safety. Published in 2020, Australia's response aspires to reduce severe, avoidable medication errors, adverse drug events, and medication-related hospital admissions by 50% by 2025. The focus areas for Australia's response were to respond to inappropriate polypharmacy, reduce the harm from high-risk medicines, and improve medication management at transitions of care. Let's talk about inappropriate polypharmacy. A lot of people aged over 55 take a lot of medicines. 95% of residential aged care residents take medications, and a large percentage of those take 10 or more medicines. There has been some developments in improving community pharmacy medication management programs in the period to 30th of June 2023. You can see from the slide that meds check services claimed rose 5%, but really importantly, home medicine reviews and residential medication reviews rose 21% in that period. And that really helps in identifying inappropriate polypharmacy. There was also multidisciplinary collaboration, and the table there shows the growth in that over the period from 2020 to 2023. Importantly, I can tell you that the services have increased in the 12 months to June 2024 as well. And I also wanted to draw your attention to the clinical care standards that have been developed for psychotropic medicines and the guidelines for appropriate use of psychotropic medicines for people living with dementia, two important factors in dealing with inappropriate polypharmacy. There are some things that still need to be done. The best possible medication history has directionally improved, but there's an opportunity to take charge of the medication review and reconciliation process through the entire patient journey. Also, medication-related hospital-acquired complications have improved for those of non-surgical in origin, but unfortunately those of surgical in origin have increased in the period ending 2021-2022. There are some tools that have been developed to reduce harm from polypharmacy in Australian hospitals, the most important of which was released by the New South Wales Therapeutic Advice Group in March 2022. What are the improvement opportunities within appropriate polypharmacy? Well, firstly, to substantially improve documenting and reporting adverse drug reactions. Secondly, to embed the generation and distribution of current medicines lists by clinicians when they're handing over care. More on that later. To advocate for the inclusion of information of de-escalation and cessation of medicines in all product information and consumer medicines information. Let's move on to high-risk medicines. Firstly, I want to say that high-risk medicine stewardship is expanding, and that's a good initiative. If we look at insulin, the rate of insulin poisonings per 100,000 hospitalisations decreased by 8% between 2015-16 and 2022-2023. From a peak in 2020-21, in the middle of COVID, rates have decreased by 10.3%. And that's against a background of increasing rates of diabetes in the community. For opioid analgesics, there was an 18% reduction in opioid medicine PBS dispensing rates nationally between 2016-17 and 2020-21, reversing the trend from the previous period of 2013-14 through 2016-17. Importantly, modified release oxycodone prescriptions dispensed decreased by 10% from just over 380,000 to just over 340,000 in the period. Unintentional drug-induced deaths involving opioids have been falling since 2018. And one of the contributing factors to that is the Opioid Analgesic Stewardship and Acute Pain Clinical Care Standard, which was released in 2022. Looking at anticoagulants, the advantages of direct-acting oral anticoagulants over warfarin therapy include their predictable pharmacokinetics and the reduced burden of the ongoing drug monitoring. Unlike warfarin, though, the effects of DOACs are not reversible. And so there is an opportunity remaining to improve the safe and quality use of anticoagulants through continuing professional development. Access to improve early career prescribers' competency with high-risk medicines is available through the National Prescribing Curriculum, now run by the University of Tasmania, and the recently researched Prescribing Safety Assessment, which has been developed by the Australasian Society of Clinical and Experimental Pharmacologists and Toxicologists. Looking at antipsychotics, there was an 11% reduction in antipsychotic PBS dispensing rates nationally in all states and territories in people aged over 65 years in the period 2016-17 through 2020-21. The proportion of geriatricians and psychiatrists prescribing antipsychotic medicines remained about the same, but the proportion of GPs prescribing antipsychotics decreased from 89% to 84%, probably in part due to the findings of the Royal Commission into Aged Care Safety and Quality and their recommendations around the use of antipsychotics. The proportion of other professionals prescribing antipsychotic medicines increased from 2 to 7%. So there's an opportunity to get to that other group of prescribers for better prescribing practices of antipsychotic medicines. Psychotropic medicines in cognitive disability or impairment clinical care standard was released earlier this year, and I commend it to you. Let's look at transitions of care, and specifically medication management at transitions of care. Up to 90% of patients may experience a change in their medicines while they're in hospital. Up to 42% may be prescribed at least one potentially inappropriate medicine at discharge. And up to 25% of adults aged 75 years and over taking 5 or more medicines had at least one potentially inappropriate medicine that contributed to their admission. I think that highlights what an important issue it is managing medication in older Australians at transitions of care. An opportunity definitely exists for the health service organisations and clinicians to embed clinical handovers based on best practice, good local policies and procedures, and training to ensure that pertinent information is communicated at handover. Professional peak bodies, state and territory health departments, universities, and the Commission have all published standards of practice, position statements, and guidelines to promote good medication reconciliation and review practices at transitions of care. While the importance of communicating the results of these for patients transitioning between care settings is widely recognised, a lot more needs to be done to translate recognition into action by both health services and clinicians. I just wanted to touch on My Health Record and the pharmacist shared medicine list, which a lot of people talk about as being a tool to assist in medication management transitions of care. Hasten to add, none of these things were designed when My Health Record was conceived for that purpose, but with 23.6 million people now having a My Health Record, which is up 4.7% over 4 years ago, and with nearly 600,000 people having pharmacist shared medicine lists, and there was none 4 years ago, there is an opportunity here for increased patient views of the pharmacist shared medicine list and increased clinician views. It's something to do. Looking at the summary here of medication management at transitions of care, it's fair to say that Australia lacks a singular, comprehensive data source to assess the extent or type of medication-related hospital admissions. There are programs designed to identify discharged older patients at the risk of hospital readmission, and they can reduce the likelihood of these patients from returning to hospital due to preventable reasons. A national time series analysis of adverse drug events using admitted hospital data over the period 2017-18 to 2021-22 showed some interesting changes. Basically, the rate of ADEs and the number of ADEs on admission dropped by around 12%. And importantly, the rate of ADE-related readmissions and the number of ADE readmissions dropped by around 17%. They're very good statistics, and we look forward to those increasing over time. So what else has the Commission done? Well, we've published a number of documents over the last 4 or 5 years. Firstly, the National Baseline Report on Quality Use of Medicines and Medicine Safety, which was published in 2021. The Opioid Analgesic Stewardship and Acute Pain Clinical Care Standard, which I've mentioned earlier, and the Psychotropic Medicines in Cognitive Disability or Impairment Clinical Care Standard, which I've also mentioned earlier. It should also be recognised that the development of new and the revision of existing high-risk medicine e-learning modules for early career clinicians is something that the Commission prides itself on and continues to develop. In addition, the Commonwealth's guiding principles for medication management in the community and for medication management in residential aged care and to achieve continuity of medication management were all co-developed by the Commission and the Department of Health, and they are landmark documents which I commend to you. Where are we with regard to Australia's response? Well, let's refresh our memories. The aspirational goal was to reduce medication errors, adverse drug events, and medication-related hospital admissions by 50% over the period to 2025. That's a big task in 5 years, and the status report demonstrates some significant improvements and steps towards reducing medication-related harms, which is great, but it also identifies progress on some priority actions and metrics where it's been challenging to deliver those. I think we've also learned, fairly importantly, that data and knowledge gaps exist. They've been identified now, and we can work to plug those gaps over the next 5 years. The importance of quality use of medicines and medicine safety as Australia's national health priority area has never been more salient. And importantly, earlier this year, the World Health Organization recognised the ongoing effort required to reduce medication-related harm through 2 documents which it released: the Global Patient Safety Action Plan 2021 to 2030 and Medication Without Harm Policy Brief, both of which implore health services around the world to continue their work in this area through to 2030. So thank you for your time this morning. The Commission aims to develop targeted work program beyond 24-25 to address the issues identified in the status report, and together we can make real improvements in reducing medication-related harm out to 2030. Thank you very much for your time today, and I hope you've learned something of where we're at June 2023 on our progress towards reducing medication-related harm. Thank you.
Thanks, Steve. Managing medicines for an ageing population is complex and challenging. Professor Jennifer Martin, physician, clinical pharmacologist, and the president of the Royal Australasian College of Physicians, shares her perspective.
Hello, I'm Jennifer Martin. I'm a physician and a clinical pharmacologist from Newcastle. Today, I'm delighted to be chatting about an issue that's very important for Australia's future health, and that's the health of our ageing population, a population that we know is going to increase in size over the next decades. I'm talking today about medication management because many of our older patients are on a lot of medications, and they also have a lot of medical comorbidities. I've got a few takeaways from the talk today that I'm going to go through now. And then I'll just go into some of the issues that I think we can do on a day-to-day basis from a clinical perspective that are really quite straightforward and we know make a significant impact on our older people's health. So firstly, I'm going to give us a bit of an understanding of physiology of ageing and why there are prescribing risks that occur with ageing. And I think it's always really important to think about physiology when we're thinking about stopping or starting a drug. Some of these issues of the physiology of ageing actually affect the pharmacokinetics and the pharmacodynamics of drugs. And that means that we get effects that we're not really expecting. But worse than that, some of these can actually cause adverse events. We need to be able to recognise adverse events when older people present to hospital with what initially seems like a new problem, because often these problems are actually due to a prescribing error or a drug interaction that we didn't think about when we started prescribing the drug. I want to talk about a risk-benefit analysis for all medications. And the good thing about that is that I'm not going to give you an algorithm today. I'm just going to give you some tips to help us think about potential risks and benefits that we should consider when we start a new medication. And I want to think about shortening medication lists. It's not uncommon, for example, for patients to be admitted to hospital on 15 or 20 medications. And most of those patients actually get prescribed 2 or 3 new ones while they're in hospital. We know that that's associated with quite a lot of medication error and also has a significant impact on health outcomes for older people. So these are our current challenges that we routinely see when we're prescribing for older adults. I've been through some of those already. We know that there are often multiple medical conditions. Patients are on multiple medications, many of which interact either with each other or with the disease that they have. We know that there's also multiple prescribers in a health system, and unfortunately, often poor communications between primary and secondary care, between secondary and aged care, and then with other prescribers that are there in the community that may not be linked in with the standard hospital prescribing system. We also know that patients drop in and out of taking supplements, complementary therapies, and other over-the-counter medicines. And these aren't always thought of as medicines by patients. However, we know that they can cause a significant number of drug interactions and a lot of harm. One of the particular issues that we're seeing increasingly in the population setting is that of cannabis. And I'm going to use that as an example. It's a drug that we don't routinely think about using in the older population. However, since we've had easier access to cannabis, it can be prescribed by cannabis clinics. We have access to unregistered products through the SASB scheme. We're now actually seeing a lot of problems in the older population. Some of the issue is because of the issues that are actually identified on the slide, that some of our older patients have dementia, some of them are troubled by delirium, particularly if they've had a stress to the system, and adding cannabis can actually give an older person significant psychosis, and that's actually often been a reason for admission, but it's something that we don't often know about unless we particularly question that. So we really need to think about some of these challenges when we're prescribing medications for our elderly population, and just to consider the effects of over-the-counter on supplementary medicines, particularly if they're not prescribed through the standard pathways. Our older patients are on lots of medications, and the scary thing is that for most of them, there's actually little evidence to support their efficacy in an older population. Now, you might think we're talking about, things like immunotherapies or some cancer therapies, but here I'm actually talking about medications such as statins, such as antihypertensive therapies. It's really important that we actually look at the evidence that we have for the use of these in the older population, because actually for most of them, we have no evidence. And like we can't assume that little children will actually respond to a medication that adults will, we actually can't assume that an older person is going to respond to a medication as a middle-aged adult. Someone that's been studied in the clinical trial might respond. So I think we have to be very careful about even our commonly used medications. And if the evidence isn't there on efficacy, maybe to think about what else we can do to help this person's condition rather than prescribing medication for which there's little evidence. The other problem with that is that there's always harm. So these medications do bind to receptors. They may not have an effect that we are expecting, but they do actually have harm to patients that are using them. So in the older population, we're actually seeing drugs being used that have little benefit, but they all have toxicity. And some of that toxicity is unrecognised, particularly if the patient has a lot of other medical problems, and if they have problems with cognitive function and can't actually tell you that they're not actually thinking the way that they used to think, or they're having problems with judgment or perception. I've talked a little bit about the adverse effects that we have with medications, and particularly in the elderly. If the drug concentrations are much higher than what we would expect when we use these in a younger population, but also some really idiosyncratic things that often turn up in older people that we're not always recognising. We've seen death from adverse effects, and one example that's quite common that I think about quite a bit is the use of statins and other therapies in older people and the risk of rhabdomyolysis and death. I've actually seen 3 of these examples in my practicing career. These are commonly used medications, but they have actually caused a lot of harm. And in those 3 cases that I've seen, have actually been a direct cause of death in an older person. So when we're using a statin, we have to actually think about if we're adding another therapy, what's that going to do to the level of statin? And is that actually going to cause renal failure, breakdown of muscle, including cardiac muscle, and death? Because it does occur, and these are real adverse effects. There are also a lot of drug-drug interactions, and I think our pharmacy colleagues are often much better at looking for drug-drug interactions, not just because of the software, but for the way that pharmacists think about the way that we use medications. I think as doctors, we're good at thinking about drug-disease interactions, but we don't always consider the effect of other drugs concentrations when we add a new drug into the system. And this is really important. It's also important to think about drug-food interactions, and particularly when a patient's coming into hospital. We know that, for example, with warfarin, which we don't use so much, but it is used still in our New South Wales hospitals in particular, that when patients change to a diet in hospital that has less of the cruciferous vegetables, that we can actually get significant drug interactions and elevated bleeding risk from the use of warfarin. The other danger of using multiple medications is just the duplication of drug therapy. And although we've tried to stamp this out by the way that we've set up systems with medicines, it is not that uncommon still to see a drug being prescribed by its generic name and then by its trade name, particularly if there's still the use of paper systems or a mixture of paper and electronic systems. So these are things that we can do from a system perspective, but certainly the more drugs that you've got, the more likely you are to have a duplication of drug therapy. And it's not necessarily just 2 drugs that are the same drug. It's actually that we can be blocking similar receptors with different drugs, or even blocking all of the receptors, for example, with the use of different therapies. An example of this would be in an older person seeing the prescription of an opioid, a drug that blocks histamine receptors, a drug that blocks dopamine and serotonergic receptors. And you're left there really thinking there's not much that's actually signalling still in that poor patient's brain. But the more drugs we've got, the more interactions there will be. We also have a problem with ineffectiveness. And I guess Parkinson's disease is a common one that we talk about with dopamine agonists and antagonists. And sometimes we have to use dopamine antagonists if we're trying to treat some of the psychosis that we can sometimes see with these conditions. But really, we have to be careful that we're actually not cancelling the effect of the two drugs out by using an agonist and an antagonist. So you really need to know your drugs pretty well if you're prescribing anywhere, but particularly in the elderly, in terms of what's an agonist, what's an antagonist, what's a partial agonist, and at what concentration will this drug actually turn from an agonist into an antagonist. So they're really important things to consider. And lastly, we've got the issue of adherence. We know that's a problem with patients generally taking medications, but the more drugs you've got, the more likely you are to have side effects. And older patients are quite good at actually realising which drugs are causing their side effects and actually stopping taking them. I don't need to necessarily go into all these adverse drug events. For all of you clinicians that are out there, you'll see these quite frequently. This is one of my favourite slides because actually it's things that I've added on there from my own experience. These are common medications that do cause adverse events. Often we think, oh, it's only the opioids that do this, but actually we get a lot of adverse events from these medications. And I think it's the right thing to do to actually go through each medication with a fine-tooth comb. You need to work with a pharmacy team and get two brains that see the issue from different perspectives and actually try to get an understanding of which of these medications could be causing adverse drug event. This is a bit of a busy slide, but essentially this is just trying to show that in Australia we're lucky enough to have high quality clinical pharmacologists and pharmacists reviewing the prevalence of ADEs in various settings, and these are very common presentations to hospital, particularly in nursing homes where often there's not as much medical observation as you might have in a ward, but we know when people come to hospital that often there's a significant amount of harm that we've been doing with the medications that we've been using for our patients in the nursing homes. I did want to mention the physiological changes with normal ageing, and I just wanted to use this to help us remember the pharmacology. And I think it's fair to say that it is very difficult to understand pharmacology if we don't understand physiology and pathophysiology. So think about what's actually happening to the normal aging body in terms of water, lipid, because that affects our volume distribution. We've got less muscle mass, so that really affects drugs like statins and whether they'll be effective or toxic. And just the fact that we clear a lot of drugs differently because our organ function changes. Well, as we've noted already, there's a number of physiological changes that occur with age. And it's not just the actual organs themselves or diminished neurotransmitters, effects on baroreceptor sensitivity, but actually there's a number of PK and other PD changes as well. The pharmacokinetic ones are absorption, distribution, metabolism, and excretion. And there's other pharmacodynamic changes as well. In the interest of time, I won't go through all those now, but they'll be in the PDF and you can look at those the summary of those changes subsequently. We're just getting really to the sort of the final few slides of this, but I didn't want to dwell on my personal experience too much, but I think I have seen a lot of harm from medication use over my time, and really, as well as harms, it's unclear to me whether we've actually provided increased efficacy for the patient that's been on them. So I think these ones in particular, because they do cause a lot of harm, we should be particularly thinking about what sort of improvement we're expecting to get from these drugs. And here we have a case example that pretty much brings all of the issues that we've talked about already to light. I'm just going to give you the case briefly. There is a lot of discussion about the significant past medical history and 28 medications that this patient's on. And I won't go into detail on those, but the slides will be available for your own learnings after this. So the case I'd like to present is a common one that we would see coming into general medicine. It's a 90-plus-year-old woman who's come in from a nursing home, and she's had a few days of a prodromal process going on, and she's actually presented with a fall, and now she has left hip pain, which actually turns out to be a fracture and she needs an operation. In this case, also highlights a number of issues around medication use in the elderly, and I'll be giving some strategies for how you might be able to think your way through this and how you might be able to manage a complicated but actually common presentations such as this one. And I think that takes me to my last slide, which is really the key points I don't want us to forget. So this is a continuous review process for older people. Every admission, every opportunity, we need to go through every medication and think about the harms and benefits. And it will change. Every 5 years, the patient gets older and their physiology changes. Do they need to still be on this drug? What's the benefit in this population? Or what's the benefit now that they've had a heart attack and we're doing something else? Consider other non-drug options. And I think that that's particularly so for things like sleeping, chronic pain, things that we know that the chemicals don't really work that well for. Please focus on the dose too. We often talk about the drug, but the dose is actually really key. We need to have the dose correct to actually treat the patient, but not to cause toxicity. And if we're starting a new drug, think about stopping a few first, but starting low and going slow. And my last point is just really to think about drugs as a cause of a patient's new presentation before making a new diagnosis and adding new drugs into it. So I think that with that, we'll just summarise a couple of places where you can get more information. There's Centres for Ageing and Health everywhere in Australia too. We've got lots of, this is Vic Health. Every state seems to have something around medication management and aged care. I tried to move it around the states a bit so that people knew that within their own state there's a lot of support. This is our Commonwealth Department of Health and Aged Care. This is talking about residential aged care facilities, but they've got good guidance here, so I think use it and make sure that you're doing the right thing. The College of General Practitioners has its silver book, medication management. Please have a look at that too, and use all the resources that you've got. And particularly when we've got pharmacologists, physicians, pharmacists, and other drug experts around, please use the team that you've got so that the patient can get the best outcome. Thank you.
Thanks, Jennifer. And to delve a little further into the challenges of medication safety for Australians as they age, we're going to introduce an expert panel, people who you've actually heard from very recently. First up, Professor Libby Roughead, the Director of the Quality Use of Medicines and Pharmacy Research Centre at the University of South Australia, Mr Steve Waller, pharmacist and Senior Advisor on the Australian Commission on Safety and Quality in Healthcare, and of course, Professor Jennifer Martin, who you just heard from, a physician, clinical pharmacologist, and President of the Royal Australasian College of Physicians. So welcome, everyone.
Lovely to be here.
Thanks, Tegan.
So Jennifer, starting with you, we're talking today obviously about an ageing population. What are some of the physiological changes that people go through as they age?
Well, there's quite a number actually, but the main ones that affect the effect of drugs are around organs and the organ functions. So the kidneys and liver that clear most of the drugs, they change, so we can't clear things as well from the system. But also the relationship of the body fat and water in the body changes significantly. So if drugs are fat soluble or water soluble, they'll distribute around the body quite differently, and particularly into the brain, which is mainly fat. So we actually see huge physiological changes that affect how the drugs get distributed around the body and how they're cleared.
And we're talking a lot today about inappropriate polypharmacy, and we do know that the volume of Australians who are older has increased greatly. And Steve, that can actually mask some of the progress that we have already made.
You mean the population growing, the size of the ageing population?
Exactly.
Sure. There's a lot more people in that age group over 65 than there were 10 or 15 years ago. And that does have ramifications, particularly when people start medicines earlier in life and expect to be on them for the duration of their life, which is not always the case, not always required. And that's what monitoring polypharmacy is all about, to determine which polypharmacy is appropriate and which is inappropriate. And if it is inappropriate, what do you do to reduce the risk of medication-related harm?
But there's some really salient examples of this. I know, Libby, you've spoken about this before. For example, proton pump inhibitors, and we reduced the use kind of per maybe 100,000 in the population, even though on paper it looks like it's static or going up. Steve, do you want to talk?
Well, I think Libby should answer that because it's her work, but that's close to the mark. Go for it, Libby.
I think two things, Tegan. I'll just answer the first bit first. We've got living for longer and we're older and sicker. So sometimes when we measure the extent of medication-related hospital admissions, it looks like we've made no progress. But in fact, the fact that we've got lots more frailer, sicker people and we're not getting more, or have only got a little bit more, means that in actual fact we've done better than we think. And the example of proton pump inhibitors, I think it's really interesting. Australia's had a lot of effort to try and reduce the overuse or the high dose use of those medicines. And we've tapered it, but it doesn't look until recently when we changed restrictions that it's dropped. But if we look at what's happened in Germany, in the UK and the other countries, we used to be the world leader. The other countries are now outstripping us and sometimes have almost doubled us.
World leader in a bad way.
Yeah, world leader in a bad way. We were overusing them. And so the efforts that we've had to try and reduce the use have actually, comparatively to global, seem to have meant that we do have better use than some other countries.
What have we done right to achieve that?
Well, I think what Australia should be really proud of the fact that we have got a cultural adoption and understanding across general practice and primary care of quality use of medicines. I think there is that understanding, and I think all of the groundwork that we've done has been extraordinarily successful. The challenge has changed though. There are new challenges, and so now the game is to say, how do we go forward when we've got a really frail older population, when we've got lots of specialty medicines, when we've got to get specialists engaged in this care, and so the challenges are new.
Mm. Yeah, and I think just coming back to that point that Libby's made, I mean, we actually have often the pharmaceutical industry coming in and marketing and selling the drug very broadly, and it often takes us a while to realise these drugs can actually be harmful to an older population, particularly in the dose that they're marketed at. But it does take us quite a bit of time often to get the educational material and start to get that interest and that team together to actually ensure that people know that proton pump inhibitors, for example, they're not just safe drugs. They actually can cause a lot of harm, and particularly in the doses that we've been marketed at, we can cause significant harm to patients. So I think there is often a lag between a new exciting drug coming in and then us actually realising, well, this is a small group of the population that may benefit a small amount from this drug. It's not really a game changer, even though that's the way I think initially it's sold to us as. So I think you've actually done a really good job in just educating people about PPIs, but we have got a huge number of classes of drugs in addition to the PPIs, but yeah, I think we have made quite a lot of inroads into that.
Steve?
Tegan, one of the other issues there is that when clinical trials are done on new medicines, they're not tested in the over 65 age group, and that creates complications because we often don't know what the impact in that older age group is. So I'm not trying to defend pharmaceutical companies here, but they don't often have that information when they are making an application for a new drug to be listed in Australia with the TGA and then listed on the PBS. So that's something that all clinicians should be aware of, that if they've got a new drug, it's not an automatic lay down misère that that's suitable for an older person.
I do want to talk about the pharma industry more broadly then and their role in this, because obviously the clinicians have a role, research and prescribers will have a role, but they're part of the system too. What could that look like to improve that, Jen?
Well, I think it's just an awareness of the limitations of the data, as Steve's just said. So often I'll say to people, why are you using a statin in this population? We know the expected life expectancy when you go to a nursing home is less than 2 years, and you have to be on this drug at this dose for 5 years to see a small reduction in a composite endpoint. And people are really quite surprised by that. They also are often unaware that there is actually no data particularly in paediatrics and the geriatric setting. So really you could argue that you shouldn't be using these drugs in populations where they're not studied. That's probably a different argument, but in terms of your question, I think people are just often unaware that when a drug comes onto the market, of the small number of people and the small number of ethnic age demographic groups. And as we've already said, the older people have completely altered physiology to younger people, so they do behave differently when we use the same drugs with them.
Libby?
I think what we all need to be aware of is companies rightly are promoting their own products, but what we need is the whole therapeutic armamentarium, including non-pharmacological activities for people to do. And so we can't just rely on information from industry. And that's where Australia, I think, has also excelled. We've got good sources of objective information with therapeutic guidelines and with the Australian Medicines Handbook. And we do have consumer medicines information. Where we need to keep going, though, is in all of those non-pharmacological interventions that are suitable for many conditions. You know, we were talking in the break about art therapy or music therapy, exercise, diet. We know compassion practices, kindness practices, which are really helpful in some of the hard to treat conditions like pain and depression. And so we need to get better at involving all of the full armamentarium of the therapeutic options. That first definition of quality use of medicines, judicious selection of management options.
And particularly when there's an underlying diagnosis of cognitive decline or dementia, all those things become into play, very much so.
And so the focus of today is very much on the medicine side of things, though. So one of the questions that we got ahead of time was from someone who was asking, whose responsibility is it to reduce polypharmacy or drive deprescribing? Steve?
It's a big question. It's everybody's responsibility, really. No single person should be identified, because the person must take charge of their decision-making, or their carers, or the people responsible for that, the prescribers, the dispensers, the nurses who administer it. So everyone has a role to play here. It's truly something that everyone needs to think of. I think one of the things that, building on some of the comments we've just made earlier, is that there's not a lot of information around about how to deprescribe all medicines. It's not compulsory to include deprescribing, by which I mean weaning and cessation information, in consumer medicines information. It's sometimes in product information, but obviously not always. And I think there's an opportunity to really change the game by making those things much more ubiquitous across the system.
Jen?
Yes, I just start with the patient first and look at all of the other influences on the patient. But it's actually fascinating when you talk to an older person as compared to a younger person, that the older person will typically say things like, oh, I don't know why they started those pills, or they put me on them. I don't think I was supposed to be on them long term, but no one stopped them, so I've just kept taking them. So I think coming back to the actual patient, why are you taking these medications? Do you want these tablets? What are your goals of care? Do you want pain relief, or are you looking for a reduction in a composite endpoint of, that's not patient language, but what actually are you looking for? Because a lot of people, particularly towards the end of life, are just looking for quality of life. And that quality of life is not necessarily losing all your cognitive function by, for example, being on heavy-duty opioids. And the opioids may play some role in pain, not actually much in chronic pain, but they certainly take away a lot of the quality of life for older people. And it's not until you actually spend the time talking to the person to find out, actually, they want to be very sharp. They think they can cope with their pain by other measures, and we can probably reduce some of their opioids. And I think that's why I sort of have difficulty with some of the algorithms, because actually it takes it away from the patient and what does the patient want here. But I think talking to the patient, and we too often talk amongst ourselves, doctors, pharmacists, sometimes with family members for an older patient, and actually it's the patient we need to really focus on here.
In the second panel that we'll have a little bit later today, we're going to talk about really practical tips for deprescribing, so make sure you stay tuned for that. Libby, I was interested in your the presentation you gave earlier. You talked about the importance of coordination, sort of structuring that. How can that be part of the solution to this question of, like, whose responsibility is it?
I think, so we've lost some of the mechanisms that we had for coordinating quality use of medicines activities. And the virtual world, it enables things like this amazing meeting, but it doesn't allow us to be in person where we can talk and discuss. So I think there's a responsibility for the country to think about how we create gathering points, nationally. For discussions of the issues that are going on. But then there's the responsibilities locally. How do we get local activity coordinated? How might we get local activity that the health professionals are involved in with the community groups, with the council, with the local activity in the area? And then there's the actual practical on the ground clinician coordinating with family members, patients themselves on what do we want. So coordination at all levels of the system is really what we need. And for those of us who run quality use of medicines activities, again, coordination and just engaging, finding out what each other's doing and making sure we're not duplicating, but we're reinforcing those messages and sharing each other's messages and activities so that we can all learn from each other.
I was going to just pick up on Libby's point about the coordination, because I think that is a really key issue for us as we continue to fragment primary care, for example, as we look at electronic systems that don't necessarily work across primary and secondary care, or secondary care and into aged care, into the transitions. Those transitions, I think there's a lot of really useful information that's lost, and we're increasingly finding that we don't have an overall coordinator of the patient and their journey in the healthcare system. That has always been the general practitioner, but as I said, we're seeing quite a fragmentation of primary care, and it doesn't really seem to be in the political dialogue at the moment of how important that general practitioner is, not just to give the primary care, but also to coordinate for that patient what's going to happen to their medications when they leave hospital, for example, and go into a nursing home. Do they still need to have 25 medications, most of which are not going to improve quality of life or life expectancy, but are just going to cause toxicity and not a very comfortable end of life? So I think that coordination, good communication, having digital systems that actually work across the whole spectrum is actually really important. An example of this would be the cannabis clinics, and maybe this is another elephant in the room, but I think that's a very good example where we've seen a lot of harm occurring for patients. But one of the biggest issues is when the patient comes to hospital, an elderly patient with their delirium, because they've been, for example, prescribed it to help them sleep, and they've now got psychosis. We don't actually have a port of call. We don't have a practitioner who's prescribed that we can ring up. And then when we send the patient home, because that general practitioner has not been involved in their care, we don't actually have a go-to person for the community when that patient's gone home. So it is actually a real problem for that person's coordination of care. So I think that's a really good point, Libby.
Steve?
Yeah, so there's a few things there we've touched on which are, fairly provocative, and rightly so. So it's all about multidisciplinary teams in acute care settings, and they have access to one another. But the multidisciplinary team in an aged care setting is much more challenging because mostly they're independent practitioners and clinicians. And then you've got the situation that Jenny just described, where you've got someone who's receiving a medicine or prescribed a medicine that their multidisciplinary team in the community is unaware of, let alone their multidisciplinary team in a hospital. And that's posing lots of challenges for acute care services when people present with these complicated medication-related harm issues from taking unregistered medicines and other things. So I think we need to understand that the acute care setting is different from primary care. Aged care is different again. People should always remember that an aged care residential facility is a home for a person. It's not a substitute for a hospital. It's because people are there because they can no longer manage the activities of daily living, and there's a care system set up around that. They go to hospital and we need to know what medicines they are arriving with, and we need to do a reconciliation and review. When they get discharged back, we need to make sure we've got a great medicines list which is communicated in a timely fashion back to their aged care facility, themselves and their GP. So there's a lot of work to do in that area, and there's a lot of work going on with the Australian Digital Health Agency talking about interoperability, but those things take time. No system's perfect. but we should never not strive to be able to deliver that seamless transmission of information, particularly medications management and transitions of care, both ways.
While we're on that, do you want to talk a bit more about that aged care on-site pharmacy and medicine reviews as part of what this solution could be?
Yeah, sure. So we've had available in the system for some time residential medication management reviews, which can be asked for by anybody and coordinated by the patient's GP, who engages usually a clinical pharmacist to do a review of the person's medication. Report comes back and that can be used by anyone. With the embedding of pharmacists within aged care facilities, the theory is that those people are available to do that for the time they're in the aged care facility. And obviously that changed. I've got to correct me if I'm wrong here. 1st of July, this year or last year, I can never remember. I think it's this year. It actually
time is a flat circle.
Time's just flying by for all of us. So that's an interesting initiative, and I think the challenge is that there's probably lots of pharmacists who are interested in pursuing that as a professional endeavour. However, there are a lot of aged care facilities that won't be in a position to employ someone 5 days a week to do that. There's some realities about the economics of residential aged care which need to be considered. So I'm hopeful that we'll have a dual system for some time so that we can embed people in residential aged care facilities where they can afford to be embedded, but we can still have people who visit and do residential medication management reviews at the behest of the person's GP.
Sure. Did you want to add that?
I do want to follow up because I think the thing that's really exciting about pharmacists in aged care is that they'll get to know people.
That's true.
You know, if I could say one thing about quality use of medicines in healthcare, it's the care word. And increasingly we've been body as machine and let's treat the body as a machine, but it's care. If we want to stop error, if we want to improve safety, improve care, we need to know people. And that was what Jenny was saying about people's goals of healthcare. It's kind of clunky language, I think, that, my mother would never like, But, when someone says to what's your goal of healthcare, she kind of goes, huh? But I think the fact that we know people, the fact that we understand when they like to sleep or don't like to sleep or what they like to eat or don't like, what they like to do, what are those non-pharmacological activities that might support them. It's the knowing people. And if we can build our system where we can create relationship, particularly in a virtual world. So this is, some of these kind of clinics, you worry about them because we lose relationship. We create. And so how do we, going forward, create and build relationship? Because when we know each other, we're all going to be safer and we're all going to feel better.
That's got to be the strength of an embedded pharmacist in aged care. That day-to-day knowledge of what the patient or the person's likes and dislikes are, and how they've been managed over a continuum as opposed to a visit that might happen once a year.
That's right.
Jen?
I was just thinking that that sort of takes us into potentially the workforce issue that we've got, and maybe this is another another very big topic, but I think the workforce in Australia is really changing. I think that what constitutes care, what constitutes medical care is really changing. And back to the point that we talked about, that you brought up, Steve, about aged care being a home for somebody. I think people think that when someone goes to an aged care facility, they're getting a nurse that can actually manage their medications and look after those aspects of it. Often it's a carer, and I think we're expecting a lot of carers. There's a high turnover of carers. There's also not the standard medical communication that you would have if it was a nurse and a pharmacist and a doctor. And so how do we actually integrate non-medical people into this whole medical discussion? Non-clinical people, I meant. Because it includes the nurse and pharmacists as well. So that workforce issue is big, but the workforce is also affecting the way we have primary care and who actually delivers care for a patient. Now, writing a script is quite different from the care aspect that a carer might give, or writing a script is quite different to knowing the physiological changes and the fact that this is actually the best way to manage a patient with this illness now. So I think as we sort of merge areas of skill sets, there's actually also a risk of knowing who does what in the scheme of things, and that's that's a big discussion, and I think we see it in the media where people actually don't know what medical is or clinical or carer, for example. So I think the language is really important, and I think the way we think about workforce and who does what, who's medico-legally responsible, who is the coordinator of care, these are big discussions I think we need to have. But without those discussions and that agreement on who's actually the responsible person, there's room to fall between the cracks, I think, and it's quite a concern.
So there's definitely some structural supports that are maybe not quite clear yet.
Yes.
The other thing that kind of came up when you were talking before about the cannabis stuff, for example, is you mentioned in your presentation, Libby, misinformation and how that's muddying the waters for people, how people perhaps are clinging to things or don't want to talk about certain medicines. How does the system cope with misinformation and health literacy in general with patients?
Oh, it looks such a big question and I don't know the answer, but I think it's one of the big challenges that we all need to understand better. I think we need to promote to people what is the sources of objective information out there. I think none of us know how to deal with social media and the misinformation, the pharma influences that people talk about. So how do you engage? I don't have solutions for this, but I can certainly, it certainly bothers us. And I think, that how do we help people understand what makes them healthy as opposed to, what's on average healthy or, because I think too much when we just talk about eat 5 veggies or, we don't tailor kind of personal health care, personal health promotion to people. And so, how do we help people have fun? How do we have when they're doing some of this stuff so that we can really promote everything and not create the understanding that it's all about a medicine. Health is rarely about a medicine. Yeah.
Steve, I could hear you getting ready to say something before.
I think source of truth in social media is always a problem. It's a problem for everything, not just health and the use of medicines in the community. But it is about making sure that when we say things as part of as practitioners, clinicians, health service organisations, aged care facilities, that our source of truth is reliable for what we're recommending, and that we make that very clear in our communications when we're discussing with the person the medicines that they've agreed to take.
Some of the misinformation is also coming through the sort of health system and the pharma model. For example, we know with gabapentin, which is a medication that some people use for pain, actually most of the information that got that onto the market was fraudulent. It was actually then a big investigation, the lawsuit's still ongoing, that there are people that actually made up that information. And I think we've seen similar work with the opioid, the big opioid epidemic in the US and here as well, that actually opioids for most conditions we use them for actually are ineffective, in particular chronic pain. And I think from the public, they're looking at their health providers saying, well, we now know this is misinformation, but you prescribed this or you continued the script. And I think we've lost a bit of engagement also with our community that actually we've used medicines inappropriately in the past. And I think that that is quite a challenge for us, where we always will have a chronic pain problem and a chronic existential distress issue. I think that's just part of human nature, but the problem we've got is that we have really medicalised this with pharmaceuticals, and when the opioid doesn't work, we add on a GABA drug, or we just add on, and we're never going to win because these things don't treat chronic pain. And these poor patients that are now on huge numbers of these drugs that are actually not helping them are really affecting their quality of life. I think we do have something to answer for there. So that misinformation is also coming, I think, from industry and from the fact that we're probably too busy to actually go back to their source material, often to actually relook at what we're actually doing here. And the educational voice, I think, is often quieter than the big, loud marketing voice for medication because there's less money. Most of us around this table are doing it on the smell of an oily rag, but Big Pharma has millions of dollars and they do it because it works. So I think that there is probably also a reason why the public is concerned about some of the prescribing, even when it's coming from actually well-trained prescribers.
Yeah.
Can I just add a couple of points to Jenny's thing there and recommend that anybody who wants to learn more about opioid analgesics should read the Opioid Analgesics Clinical Care Standard in acute pain.
Seamless plug.
I had to get that plug in because that actually talks about some of the things that Jenny's alluded to there. But I'd also want to end on a good note. Opioid deaths in Australia are down over the last 5 years, which is something that hasn't occurred in North America. So the opioid crisis, which was mooted to be expanding here in 2017-18, has largely been averted due to changes in practice. We need more changes in practice to ensure that that happens, continues to trend in that right direction. And we also need to stop using opioids for chronic pain. There's limited, no evidence to suggest that it works, and we need to be very judicious about our use of modified release opioid analgesics.
Thank you.
Can I just
gonna
follow
say.
though? Well, I just think, so it's not that I disagree, but I think what we have to remember is that the people in front of us are often suffering, and that's what Jenny alluded to. And so as we do that work, bringing the compassion to the encounter as opposed to a no, you can't have to the encounter, and thinking about how we get all of those other strategies in place. So hopefully people will talk about this in the deprescribing panel, but it's not just ceasing a medicine, it's ceasing a medicine and starting the other things that you might need to help you be well. Whether it be an exercise program or a psychological services or some kind of other thing, but it's the and, particularly in the pain and
I think that's really
distress
particularly
space.
Chronic pain.
Just chronic pain and distress space.
We need to fund more clinical psychology, for example, and other allied health work that is known to actually help people with chronic pain. So I agree, Libby, you have to have something else for people that have chronic pain, but we shouldn't be continuing to use medicines that don't work. But just on your point, Steve, about the deprescribing, I think there's been a lot of work with state formularies, and even within New South Wales, the Clinical Excellence Commission, we have actually reduced the number of opioids that people can prescribe to actually get that whole conversation going of why do you need to have access to 10 different opioids in an inpatient setting? Why do you need all these different concentrations? And these are discussions that we hadn't really had. And so I think there are successes around Australia. We've been copying the South Australian formulary and the Queensland Health. So I think we are sort of coming all together to realise actually we just need to ask the question, why do we have access to all these drugs that are not any more help than some of the other therapies?
Yeah. So just bringing it back to, in broad brush strokes, this idea of inappropriate polypharmacy, deprescribing, I'd love to sort of hear from each of you to close, like where you think we're doing really well in this space and then what has to be next. Libby, do you want to kick us off?
Oh, golly, that's a hard question to finish
Just one
with.
and then one.
Look, if I had my wish list, it would be how do we expand the resources around the non-pharmacological approaches. I think judicious selection of management options is one of the places we've done poorly on. I think in general, we've got the resources and things in place for appropriate selection of medicines, and I think with all the deprescribing stuff that's coming, we're good on the safe and effective, we're improving on the safe and effective use, and then I think the big issue is then the coordination of it all to get us all healthy.
Yeah. Jen?
I had this rule on the ward round, which is if you're starting anything in someone over 65, you start one, you have to take 2 off. And sometimes you can actually take more than 2 off over a period of time, but it makes you think, I'm contributing to this problem by adding something. So what actually is the incremental cost and benefit of adding this therapy? So I think that behaviour change needs to occur, but I actually think it's the transitions of care where we can make the most impact for medicine safety out in the population, so that communication, the collaboration, the dialogue between primary care, the hospital, and if people go back into residential care, I think that we can make a real difference there.
Sure. And Steve?
Very similar to the 2 previous responses. Just to be a little bit different, probably I think there's a real opportunity to improve prescribing by early career clinicians. And they are the ones who write most of the discharge summaries in the acute care sector. So if we can improve their knowledge of inappropriate polypharmacy and having them think about what they're putting on the discharge medicines list would be helpful. So things like the National Prescribing Curriculum, the new initiative by ASCEPT to educate young prescribers in that. And it becomes even more important in primary care when we've got increased prescribing rights with nurse practitioners, potentially pharmacists, podiatrists and other allied health people. So understanding that prescribing is not the only solution, which I guess builds on Libby's point, and when we do prescribe sensibly, appropriately and judiciously.
Oh, thank you all so much for sharing your insights.
Thank you, Tegan.
And we've had lots of questions from you about whether these sessions are going to be available after the day. Yes, of course they are. Keep an eye on your inbox for that so you can watch them back again and again as you fall asleep each night. Coming up next, we're going to explore deprescribing, focusing on practical strategies and communication skills to support clinicians engage patients in meaningful conversations. So stay tuned for that. But for now, we have a lightning talk from the Pharmaceutical Society of Australia, followed by a short break. We'll see you soon.